All right, class, we're going to continue with our next exemplar, which is called deep vein thrombosis. And just a little overview. First of all, you might have heard the term thrombophlebitis. We sometimes refer that to as phlebitis. Maybe you've seen a patient have an IV in and the area gets very red. Patient complains of pain in the area, might even become a little bit swollen. That's what we know as a phlebitis. It's a condition in which a blood clot forms and blocks one or more of the veins. And clots can typically form in the legs, but can form in the arms and neck, but only in rare instances, okay? So when the blockage occurs near the skin surface, it is known as a superficial thrombophlebitis. When it occurs deep in a muscle, it is known as a deep venous thrombosis. And DVTs typically occur in the large veins of the lower leg and thigh. And what is a thrombus? I think that's the first thing we need to go over so everybody understands that term. A thrombus is a clot that forms in a vein or it forms in an artery. The formation of a clot is referred to as a thrombus. And when the formation occurs in a vein, that's when we call it a venous thrombosis. And DVTs are the result of venous thrombosis deep in the muscle tissue. And the blood clot involved in DVT can actually travel upward to the lungs. And when this occurs, this is when a patient develops what we call a pulmonary embolus. And depending on the size and to where that thrombus lodges in the circulatory system of the pulmonary system, it can be very life-threatening. Many times these conditions occur together, and they are collectively referred to as a venous thromboembolism. And as you can see from the slide, as we're going to continue with this, three pathologic factors called Virchow's triad are associated with the formation of a thrombus, and that includes circulatory status, or status of the blood where the blood isn't really flowing as good as it should, vascular damage, and hypercoagulability, okay? And when you have vascular damage, that stimulates the clotting cascade. And what happens during that process is platelets start to gather or aggregate at the site of the trauma, particularly when the circulatory stasis is present. So then you have platelets and fibrin forming the initial clot, and then you have red blood cells become trapped in that fibrin meshwork, and then the thrombus starts to grow in the direction of the blood flow. And this, of course, triggers that inflammatory response, causing the person to complain of, it's very tender to touch, swelling, and erythema in the area of the thrombus. And erythema refers to the color of that area, and it will get very red. And so the thrombus will initially float within the vein, and then pieces of that thrombus start to break loose, and that's where they start to travel through the circulation, and we know that as an emboli. And then fibroblasts eventually invade the thrombus, scarring the vein wall, and they also destroy the venous valves. And so you have permanent valve damage may occur because of a thrombus, even if the valve patency is restored. So valve damage will most likely affect directional flow. And if you look on page 1212 of your Pearson book, you'll see some pictures at the bottom of the page where it shows some common locations of where these venous thrombosis occur. And you can see that many times they occur in the calf, and sometimes they may be in the upper portion of the veins of the leg, kind of in the back of the leg, as you can see from the second picture. And then, of course, they occur in the femoral vein, in the popliteal vein, in the posterior tibial vein, and in the greater saphenous vein. Okay? And remember, deep venous thrombi occur in the deep veins of the body that lead to the vena cava. And the deep veins of the legs, primarily in the calves of the pelvis, provide the most hospital environment for venous thrombosis. There are also deep veins in your arms, they're also in your chest, in your neck, but thrombi typically do not form in these locations. About 1/2 of DVTs are asymptomatic, so if symptoms are present, they depend on the clot's location and size, and that's what I said earlier. When these actually travel through the circulation, go up into the pulmonary system, the patient's manifestations and symptoms will definitely depend on the size of that emboli or where it's actually located. All right. And as you can see, deep or superficial veins, as I just talked about, and they're a common complication of hospitalization and surgery, especially in OB and orthopedic surgeries. And again, a review of the clinical manifestations: calf pain, dull, aching, increases with walking. There's tenderness, swelling, warmth, erythema, sometimes cyanosis, and even swelling and edema. And the important thing is to establish the diagnosis, prevent further clotting or extension of the clot, and to address the underlying causes. When these are developed, it's really important to know what the etiology of these thrombus are. They just don't appear out of nowhere. There are some diagnostic studies that can be done to determine, the visualization of these clots. And the first one is a duplex venous ultrasonography, and this is a non-invasive test used to visualize the vein and measure the velocity of the blood flow in the vein. So they're kind of seeing the size of it to kind of understand how well the blood is flowing through that particular vein. Although the clot cannot be visualized directly, its presence can be inferred by an ability to compress the vein during the examination. All right. The next one is a plethysmography, and this is where they again have the patient involved in another non-invasive test that measures changes in blood flow through the veins. It is often used in conjunction with the Doppler ultrasonography, and plethysmography is the most valuable in diagnosing thromboses of larger or more superficial veins. And then, of course, an MRI is a non-invasive means of detecting DVT. It is particularly useful when the thrombus of the vena cava or pelvic veins is suspected. Obviously, those are larger areas too. But remember, with some MRIs, you have to make sure you know about any type of metal apparatus or devices that are implanted in your patient, because that would be contraindicated. And of course, an ascending contrast phenography is used. This is where they actually inject contrast medium to look at the location and extent of the venous thrombosis. And although invasive, expensive, and uncomfortable, contrast phenography is the most accurate diagnostic tool for venous thrombosis. It is used when the results of less invasive tests leave the diagnosis unclear. So that's why you would use each of those. All right. And prophylactically, when we know patients are at high risk for developing DVTs, we put them on a low molecular weight heparin to prevent and treat some of these venous thrombosis. And these medications are much more effective and carry lower risk for bleeding and thrombocytopenia than your conventional unfractionated heparins. And they also don't require the patient to have frequent laboratory monitoring of unfractionated heparins. I'm not going to get into the action of these, but I just wanted to have you understand why those particular drugs are chosen. Oral anticoagulation. Sometimes your direct thrombin inhibitors are advantageous in that they inactivate both free and bound thrombin, and your patients may be placed on those as well. Also, elevating the foot of the bed with the knee slightly flexed, getting the patient out of bed, getting them moving, encouraging leg exercises by the patient themselves, or intermittent pneumatic compression devices. But please be sure if those are ordered that they're on the patient. I can't tell you how many times I've seen the patient have that ordered, and then you come into the room and they're laying in the bed or the machine is turned off. There's a reason why those are ordered for the patient, and they need to be put on until the order is discontinued. Make sure after a bath that they're reapplied to the patient and that the machine is turned on. And of course, we might see elastic stockings as well. And we talked a little bit about those, or TED hoses. You may know them from before. Now, those are prophylactic ways in which we hopefully prevent the patient from getting a DVT. But when they do have a DVT, surgery might also be an option as well. Most of the times we can treat with conservative measures and anticoagulation, but in some cases surgery is required to actually remove the thrombus and prevent it from extending into the deep veins, or to prevent the effects of immobilization. And the first thing that might be done is a venous thrombectomy. And this is done when the thrombi lodges in the femoral vein, and their removal is necessary to prevent either a PE, because it's going to break off and travel up into the lungs, or gangrene, when it'll cut off actually blood flow to that area. So a successful thrombus removal rapidly improves that venous circulation, and the duration of this effect varies from patient to patient. So some patients, it's contraindicated for them to be on any type of anticoagulant therapy. So what they might put in is a filter, maybe put in into the vena cava to capture those emboli from the pelvis and lower extremities and prevent it from going up into the lungs and causing the patient to develop a PE. There is a picture of these filters on page 1217. You might know them more familiarly as a Greenfield filter. The Greenfield filter is widely used for its ability to trap emboli within its apex while maintaining patency of the vena cava. A lot of your cardiologists will insert these into patients. The filter can be inserted under fluoroscopy with just a local anesthesia. The mortality and the morbidity associated with these filters are very low, and now they have the kind that actually can be removed and have them replaced. Before, the old version of them, they were in the patient forever and ever, but now they can actually take out a filter and reinsert another one, especially if it's been catching a lot of that emboli, and the patient is more prone to developing that. Some of your superficial thrombophlebitis of the great saphenous veins can progress to DVTs, and it may be treated by ligating and dividing the vein where it joins the femoral vein to prevent clot's extension into the deep venous system. So that's what we mean by vein ligation, okay? Sometimes the super thrombophlebitis that involves infection can lead to septic venous thrombosis, and when this occurs, the affected vein is excised to control infection. And again, with this, you might see the patient put on an antibiotic. Some of the clinical therapies that we do is measures to reduce symptoms and inflammation. We might put on warm, moist compresses, extremity rest, anti-inflammatory agents. Sometimes the patients are put on bed rest, elevating the legs and putting on anti-embolism stockings and those PCDs. And again, we want our patients to return to activity, encourage walking, avoid prolonged sitting, standing, avoid crossing legs, avoid tight-fitting garments. I want you to look at all the various age groups across the lifespan, thinking about infants and children. DVTs are pretty rare in children. It's mostly associated with babies who are premature or sepsis that predisposes newborns to DVT. When a child might have a DVT, they're usually asymptomatic. When symptoms do occur, they are nonspecific and include acute pain and swelling of the extremities. And usually the initial treatment includes unfractionated or low molecular weight heparin over time. And then the patient will be put on oral warfarin. Now, DVT in adolescents and young adults is 8 times greater than in infants and young children, although the risk for this group is still lower than that of the general population, okay? And during adolescence and young adulthood, thrombosis is twice as likely to occur in female patients as in male patients, whereas in the general population, male patients have a slightly higher risk. One factor we know with young women that predisposes them to DVTs is the use of contraceptives that contain estrogen and progestin, often called combined hormonal contraception. And symptoms of DVTs in adolescents and young adults include basically the same manifestations of pain, swelling, warmth, and tenderness of the extremity. And remember, when you do have young women who do develop a DVT and they're put on anticoagulant therapy, remember they may experience very heavy menstrual bleeding. And so when this occurs, patients should continue with therapy and receive counseling about managing menstrual flow, because a lot of these patients may develop some serious anemia problems as well. Remember, sexually active young women taking warfarin should use birth control because of the teratogenic effects of the drug, but it is important that these patients avoid combined hormonal contraceptives. We know DVTs is also a probability with patients who are pregnant, especially the first few weeks of the postnatal period, as a woman's risk of DVT and PE are 4 to 5 times higher than that of a woman of the same age who is not pregnant. A lot of these women may develop inherited clotting disorders, further increasing their risk to develop a DVT. DVTs during pregnancy is more likely to occur in the left leg than the right leg, and that is believed to be due to compression of the left iliac vein by the right iliac artery. And usually heparin is the preferred anticoagulant in pregnant women because it does not cross the placenta. So you'll be learning about these in your Nursing 123. Warfarin or Coumadin can cross the placenta and has teratogenic effects on the fetus, and patients should be monitored for progressive VTE and heparin allergies for the duration of anticoagulation therapy. And then, of course, DVTs in an older adult. Obviously, age is a risk factor for DVTs, and the risk for thrombosis increases 30-fold between ages 30 and age 80. And DVT is usually asymptomatic in the older adult. When symptoms occur, they are nonspecific. And usually what we see with these patients are a patient's known comorbidities may have symptoms in common with the DVT. That complicates how we're able to diagnose the problem. So age-related body changes can lead to false positives on their D-dimer test, and additional testing is often necessary to confirm those diagnoses. So it's necessary that we do some of those diagnostic testing that I talked about earlier. And we do see anticoagulant therapy commonly used to treat older adults with DVTs. But of course, now we have older adults who are at a higher risk for bleeding. And they have a lot of multiple comorbidities, such as decreased kidney function, decreased body weight, and of course some of them develop dementia. and they're also at risk for falls, which complicate the use of anticoagulant therapy in older adults, especially if they fall and they hit their head. They could have a bleed in their brain. So again, to determine if the patient does have a DVT, it's really about observation and interviewing the patient, doing a physical exam on him, and if it is verified that the patient does have a DVT, then we should help them manage pain, regularly assess that pain, the location, the characteristics, and asking them about what level of pain they're experiencing. And we might also see a need to measure the calf and thigh diameter of the affected extremity. We may want to apply warm, moist heat to the affected extremity at least 4 times a day. Some of them may need to maintain bed rest because using leg muscles during walking exacerbates the inflammatory process and also increases the edema. And this in turn will increase venous compression and increase the pain that the patient experiences. And again, assessing for effective peripheral perfusion, assessing the skin of the affected lower leg and foot at least every 8 hours or often more as indicated. Elevate the patient's extremities at all times, keeping those legs, the knees slightly flexed and legs above the level of the heart. And using mild soaps, solutions, and lotions to clean the affected leg and foot daily, but they should be padded, dry after washing, and apply a non-alcohol-based lotion or moisturizing cream. Because if you start using some harsh soaps on those areas, it really starts cracking the skin, and then the patient is at risk for infection. Many times an egg crate mattress or sheepskin on the bed as needed. And of course, encouraging the patient to change their positions at least every 2 hours while awake, and reducing the risk for injury, making sure we're monitoring the essential labs that are done, such as an INR, an APTT, hemoglobin, and hematocrit, and then of course report any values that are outside the normal range. And then when the patient is up to it, encourage mobility, range of motion, frequent change in positions, and of course encourage increased fluid and dietary fiber. And then encouraging and maybe assisting the patient when they ambulate, and giving them activities to do to avoid boredom, and promote effective cardiopulmonary perfusion, because we worry about the fact that this can travel and go up into the lungs. So we definitely frequently assess the patient's respiratory status. And we might have to initiate oxygen therapy, position the patient so that they're able to breathe more easily. There is a nice box on page 1221 that talks about home care for DVTs. Obviously explain to them in simple terms so that they can understand their disease process. Treatment measures, including laboratory tests, and why they have to have those, and of course about the medications they're on, the possible side effects that go with those medications, appropriate methods of heat, and explaining to them the possible restrictions they may have, and measures that prevent a future episode of a DVT, and of course their follow-up care. Seeing their healthcare provider, and maybe again continuing to obtain necessary labs. So these are all important that we continue to educate your patients about these. So I hope that explains DVT somewhat more, and learning about the terms. So now what we'll do is just do a couple exercises and activities from your appendix. Okay, the last couple things that I want to do is look at Appendix 27 that has you kind of look at these particular occupations: factory workers, desk jobs, people who fly a lot, such as flight attendants, pilots, even truck drivers. Discuss strategies to reduce the onset of deep vein thrombosis for high-risk clients who have occupations in which their physical activity is limited. Create a teaching sheet that could be used for a client employed in each of the occupations listed below. Think about your factory workers. They stand a lot. Many of them are on assembly lines. So you want to kind of increase circulation. So we would encourage a lot of these stagnant people who are sitting at desk, sitting on an airplane, that they get up and move around, do active range of motion exercises, dorsiflexion of the extremities to keep that flow of blood in the lower extremities going, because that's how the movement of blood through the veins is precipitated, is by the action of the muscles. Of course, truck drivers who sit in their cabs for a long period of time are also prone to DVTs. So a lot of the clinical therapies that we talked about earlier on the PowerPoint would definitely be indicated for these types of workers as well. And then if we look at the next question and answer sheet on Appendix 28. What strategies can you implement to reduce the risk of DVTs in a patient or a client who is confined to bed? Obviously, we would put them on some kind of anticoagulant prophylactically to prevent the possibility of a DVT from immobility. Again, to try to move the patient every 2 hours, changing their position, and maybe giving them full assistance to get up in a chair as well. And then to encourage active and passive range of motion exercises. Develop a teaching plan aimed at reducing the risk of DVTs in older clients who has limited mobility. A person who has limited mobility can be taught some active and passive exercises and can move the legs and feet while sitting. If a patient can walk at all, he or she should be advised to get up every hour and walk a little, plus the client should not cross their legs as well. So what about a pregnant client who's at risk for DVTs? The pregnant client is at risk for DVTs because the expanding uterus puts pressure on those blood vessels. It restricts blood flow from the legs and the pelvic back to the heart. Slower blood flow increases the risk of deep vein thrombosis. Also the hormonal changes that contribute to coagulability. And I just got done talking about that particular population. Explain the specific factors that increase risk for DVTs at each stage of pregnancy, prenatal, antenatal, and postpartum. Obviously, prenatal are birth control pills or anyone that has a history of a DVT. Antenatal is increase in the size of the uterus, and hormonal changes contribute to DVT, as discussed in question 3. And then postpartum, still a rest during the immediate postpartum period until the hormones begin to return to normal, and as well as a woman's activity returning to normal as well. So that pretty much concludes our exemplar of DVTs or deep vein thrombosis. Make sure you do your reading, and you may want to review these exercises again and maybe come up with some answers on your own as well. Please let me know if you have any questions, and have a great day.